Chapter 17, Part 2, continuing our conversation regarding neurologic emergency. So we were talking about seizures and the types of seizures, and now let's look at the causes of seizures. Patients may be epileptic, which means they are congenital seizures, something that occurred at birth or they've had since birth, though the seizures may not begin occurring until later. It could be a problem with the structure of the neurological system, so head trauma, stroke, maybe even an infection or a tumor. Metabolic causes are an issue within the breakdown or chemical structure of the body because of drugs or withdrawal from alcohol. One of the reasons why they have limited the close of ABC stores is the concern of the alcoholics and where they would get their alcohol from and not go into withdrawals. Low blood sugar and low oxygen. And then the one that gets parents a lot is febrile seizures. Febrile seizures are those caused by sudden high fever. Those epileptics who are diagnosed with seizures are able to get medication that when they keep it at the right level, they're going to be able to minimize or even completely prevent seizures. And this is just kind of a list of medications you might hear. The big ones being Dilantin, Tegretol, Depakote, and Topamax. And Klonopin too, but I mean, in reality, they're all drugs you'll hear. As we talked about when we initially talked about drugs, is make sure that if you're not sure what the drug is for, that you ask your patient if possible. We know that, as I said, seizures can be caused by structural issues. When patients have seizures that have no origin, they've had no history, there's the likelihood that they're going to have an MRI to kind of make sure that the structure of the neurological system has not been negatively impacted by something. There's metabolic causes or things that we have to prevent through good medical treatment, through taking our medications as we're supposed to, and also through not taking things that we shouldn't. Just at a certain point, overdosing can cause seizures, but so can just taking a drug that throws off the chemical balance of the brain. We need to recognize seizures, and we need to teach people how to recognize seizures so that they can take the steps to prevent further injury to the patient and also get medical care. The recognition comes from understanding that because of that lack of breathing during a seizure, the patient may be cyanotic, or they may, if it's not a full seizure, tonic-clonic seizure, they may have irregular breathing. If they are diabetic, they may see, if it wasn't a seizure caused by low blood sugar, they may see low blood sugar after the seizure, because a seizure is the firing of electrical activity in the brain that then causes muscular movement. You're looking at a person who is burning a lot of energy, and of course you need glucose for energy. So they are burning a lot of their glucose. One of the things we can do post-seizure is check a blood sugar to make sure it's appropriate. We need to look for other problems that may occur because of the seizure or are what caused the seizure. So if they had a head injury that then caused a seizure, don't get caught on the movement of the patient. We're still going to need to do a full physical assessment. And seizure patients, it's great to do a head to toe anyways, because if they were in a standing or seated position and fell to the ground, there is a high probability that they will have some type of other physical injury as a result of the fall. After the seizure is that post-ictal state. So remember, this is that 5 to 30 minute period after the seizure where we're looking for that patient to start to come back to normal, for lack of a better word. So the muscles are going to relax and the breathing will become labored because the body's trying to correct the hypoxia. And then within minutes, we hope, they're going to start to breathe more regularly. We have to make sure that we monitor the breathing, because if something else is going on, that breathing may stay irregular. We've got to recognize that the postictal state can also be very characteristic of a stroke. So our patients may have paralysis on one half of the body based on how the brain is recovering from that electrical storm that happened. But it's most commonly going to be characterized by a patient who appears tired, kind of very lethargic, so slow to respond, maybe confused or combative. So you need to be prepared for all of them. If they don't come out of the seizure and don't come out of the postictal state, especially, and stay confused, stay very disoriented, you need to check their sugars, and you need to be concerned that the cause of the seizure is something that still exists inside the body. Unfortunately, many people don't understand the difference between syncope and seizures. Syncope is fainting. It is the reaction of inability of the body due to something to adjust the vessel size to ensure blood pressure maintains appropriately. So when someone stands up too quickly, or if you've ever been crouching and stood up too quickly, started to have that blackout, where your peripheral vision starts to go, that is or close to syncopal episode. But the difference is seizures can occur in any position, and again has that cause. Syncope normally has a patient who may faint and then comes to very suddenly as the body reacts. Now, they've got the same potential for traumatic injury in the fall as a seizure patient, but normally once they come to, they're not going to have that level of confusion that your seizure patient does. In general, we are going to get called as well for altered mental status. And this is just somebody who doesn't have that level of awareness to person, place, time, and events. It's someone who's unconscious, because that is obviously altered. And so you've got to understand, though, that this is not always a stroke or a seizure. There could be many other causes to altered mental status. And through our assessment, we may either find the cause, or we may at least start treating all the known causes. One cause is hypoglycemia. Patients who have low blood sugar are going to mimic the signs and symptoms of stroke and potentially seizures. They may have that paralysis of half the body, which is that hemiparesis. You may have a patient who can kind of communicate. They may be alert, or at least not alert, but responsive to verbal stimulus. But more than likely, patients who have low blood sugar are going to have an altered or decreased level of consciousness. The potential exists that they don't have a history of diabetes or low blood sugar, but what's happened is they've taken medications or are fighting an illness that has caused it. Now, these patients can also experience seizures, which of course means then you're treating both the low blood sugar and the seizures. And without treatment, the mental status is not likely to improve. This isn't a postictal state, and that's kind of how you may know the difference. You also will know the difference if you test their blood sugar. Delirium is another type of altered mental status that you need to be concerned about. And delirium is a symptom of another issue. It is not the disease itself. Delirium is defined as that state that may have a physical or mental cause. It's temporary. They don't know who they are. They're unsure of the time period or where they're at. And this is often caused by infection, medication changes, or low blood oxygen levels, which when treated will remove the delirious state. Delirium has multiple signs and symptoms that you can look out for, including disorganized thoughts, delusions, that decreased level of consciousness, hallucinations, so seeing or hearing things that aren't really there, and striking changes in their personality and their emotional display. And they may mimic intoxication, drug abuse, or something else. So again, seeing a patient with an altered mental status, do not automatically assume that they're drunk. Don't assume that they're diabetic, and certainly don't assume that it's a stroke or a seizure unless they meet those signs and symptoms. And that's more than just what you'll see through delirium. If you assume things, you'll lose the opportunity to reverse the impacts of whatever the problem is. We've got to consider all of the other causes as well. If they're intoxicated, they're intoxicated. There doesn't always have to be that problem. Psychological disorders, multiple medications that are interacting with each other can cause altered mental status, infections. All of these are issues that could exist, and you get to play detective, and you may not ever know the answer, and you may not ever have the solution, but what we do is treat the signs and symptoms. But first, we've got to get to the point where we know it's altered mental status, and that is done through our medical patient assessment. We start with every other call, and that's seeing safety. With the dispatch information, we may have an idea that this patient is combative or acting inappropriately, or it really is a seizure. But we need to not be distracted by anything on the scene that may pull us away from looking at all of the potential issues, such as family members who are frightened or who are claiming it's one thing when it really could be another. Remember, the general public doesn't always know the difference between the causes of altered mental status either. And we have to, especially in our seizure patients, consider the need for spinal immobilization. We're going to look for the clues of the nature of illness, try to determine whether or not there are signs of trauma or the potential for trauma, or if there's belief that there is a previous medical condition. We definitely want to know how long this has been going on. So we're asking the family member, when was the last time they were acting their normal selves? Check the airway and breathing, especially for your seizure patients, but even stroke victims are going to lose some of the functionality of their airway structure. Be prepared for suction. Positioning of your patient is going to be key at airway and breathing here so that they're not at risk for aspiration. We need to make sure we give them high flow oxygen, because if the hypoxia is a cause of it, it will help. But many of these patients likely need oxygen anyways due to the body's reaction to the altered mental status. If your patient is not breathing appropriately, so irregularly, their rate is too slow or too fast, ventilate once every 5 seconds so that you get a rate of 10 to 12 breaths per minute. Don't hyperventilate. Don't get distracted. If you are bagging your patient, that should be your focus. You shouldn't be trying to direct the call because you're not going to be counting correctly. And you have that risk of causing your patient to have a decreased cardiac output because of the increased pressure in the chest cavity, for an increase in the intracranial pressure, which then can cause further bleeding if they've already got a bleed. And you also have that potential to cause gastric distension, which can lead to regurgitation and aspiration. Go to your pulse check. carotid and radial pulses. And if there's no pulse, obviously start CPR. An unconscious patient has the potential that this was a cardiac or has led to a cardiac issue. If they're responsive, is the pulse strong, adequate, appropriate? Are there any major bleeds? And if so, treat them. It's all the same. Airway, breathing, circulation, primary assessment. There might be some extras, but in reality, all of our patients should be given the same considerations for their A's, their B's, and their C's. Make your transport decision. An altered mental status patient is a load and go, especially if you suspect a stroke, because time is critical in stroke patients to get additional treatment. We need to do our history taking, work with the family or bystanders to try to get an understanding of what happened to the point before they changed their level of consciousness. Look for some of the potential signs and symptoms of strokes and seizures, so weakness, paralysis. In seizures, you may see a patient who is incontinent, so they've lost control of their bowel and bladder or bitten their tongue, though that's not a guarantee. And if they're responsive, ask them what happened, why 911 was called, what was the situation before your arrival. We need that sample history and that OPQRST. Understanding the history of the patient, the medications they're on, also getting that information on what was the onset, when was the last time they were seen behaving normally. It's all going to help us get a better understanding of where this patient's coming from and what is happening to them. Remember that the physical examination can give you a lot of information as well, so that you can determine if there's some type of traumatic injury that may be causing this, head injury, and potentially getting that pulse, movement, and sensation check will show you if your patient is having a stroke, because you'll see that weakness on one side of the body as a result of that stroke. But if you don't do your neurologic check, checking for the pulse, can you wiggle, can you squeeze, can you push down, can you pull up, then you're not going to get that patient's response and you're not going to have an understanding of what's happening. The vital signs are going to be key in this patient, because vital signs will show you if there is an intracranial bleed. As the pressure builds up, you'll see changes in the pulse and respirations, and also may see a significant increase in the blood pressure as well. We've got to make sure that if our patient is altered mental status, we are taking their blood sugar, because obviously this could be both the cause and it could be an underlying symptom. We've got the important part is also that monitoring of the vital signs every 5 minutes. If we believe this is a stroke, or if we haven't really found the reason that the patient is altered, then we need to consider evaluating them for a stroke. And you can use one of multiple different stroke scales, but they all basically focus on the same thing, and that is the face, the arms, and the speech. The one that I learned coming up was the Cincinnati Pre-Hospital Stroke Scale. But the Los Angeles Pre-Hospital Stroke Scale and the Stroke Severity Scale have all they all do the same thing. One is not necessarily better than the other, because they're all looking at arms, face, and speech to determine whether or not the victim has a potential for having a stroke. And the fast mnemonic, so looking for facial droopage, which in that top picture you see, determining whether there's arm drift, can they speak, do they have proper speech, and how long has it been, is going to help you both evaluate for stroke and get them to the hospital quickly. So with facial droopage, when you look at them, does one side of their face kind of sag lower than the other? Arm drift, ask them to hold their arms up closing their eyes, so their arms should be held up in front of them and close their eyes. We will often see an arm that starts to kind of fall down and doesn't maintain because of that muscle control that is lost during the stroke. Speech. Ask them to repeat a phrase. A common one is, "You can't teach an old dog new tricks." When we talked in part 1, we talked about the fact that different areas of the brain control different things. If they slur it but can say it, that's going to be one area of the brain. If they say it but use the wrong words, that's going to be another area of the brain where the stroke is occurring. And finally, if they can't say it at all, then we've got a big issue. This table 17.3 shows you what you're looking for, abnormal response, and kind of what you can expect to see or hope to see if the patient is having a stroke. You can see the pre-hospital stroke scale from Los Angeles is a bit more specific. So you're looking at the risk. So, patient that's older, they have an absent history of seizures. So this isn't a seizure. Looking at blood sugar levels, any obvious asymmetry. So this scale actually rules out other causes and then looks at specifically the issues associated with stroke. And then that 3 item, we're actually rating them based on the dysfunction. So the Cincinnati pre-hospital is more of a yes/no. And this one actually gives you, is it mild, normal, or severe? We also need to make sure that any patient with altered mental status is evaluated with the Glasgow Coma Scale. And the Glasgow Coma Scale kind of looks at how your patient's neurologic status is. And you need to really kind of highlight and mark table 17.6. When you're taking a trauma patient into MCV, they're going to want to know what the GCS is, the Glasgow Coma Scale. And, each has a scale from a top normal function to the lowest non-function. And here's the way to remember this, okay? So, and roll your eyes as I say this, but 4 eyes. If you wear glasses, you're 4-eyed. So 4 is the best score in eye opening. So with the eyes, the 4 eyes, if they're opening their eyes on their own, they're blinking, it's normal, then they get a 4. If they're only doing it in response to speech or in response to pain, then obviously that goes down. And then if they don't do it at all, they get a 1. There's no 0. Under the verbal response, to the best way to remember how many, what the top score is think of the Jackson 5, the singing group. Because, they sing, they've got a verbal response. Top score, best oriented conversation being 5. And then as you get confused or inappropriate words or just mumbling, you go down from 5 to 1. And then motor response. So we're looking at the ability of the muscles and the patient's ability to control their motor response. Top score is 6. And remember, a V6 engine. So a V6 engine is going to move the car, and a person who gets motor response 6 is going to move their body. We would hope to see a patient who is, top score, so that puts them at 15. But when we see some mild dysfunction, it's going to be 13 to 15. A patient who is in a 9 to 12 range, we're getting some moderate dysfunction. And anyone that is 8 or less, we've got big issues. So that is your Glasgow Coma Scale. In our reassessment, we've definitely got to get back to the patient's ABCs and their vital signs, because these patients can go unconscious if they were only semi-conscious. They may come to. A compromised airway is a pretty big risk. And so we've got to consider both multiple interventions and the potential for our patient to change their level of consciousness and change their priority status if we're treating them as a stay and play. Interventions that you may have, airway adjuncts, so they may get a nasal airway. Remember, altered mental status, but with a gag reflex, consider that nasal airway. Positive pressure ventilations, you may be bagging your patient, suctioning your patient. It's possible that your patient requires a medication. And in an unconscious or semi-conscious, that's going to be an ALS intervention, but you might be there to support them. We've definitely got to notify the hospital if we suspect a stroke, and we've got to transport to a facility that is designed to assist in treating strokes. You've got to let them know, it has been 30 minutes since my patient was last seen healthy, or, they went to bed, and because time is important. After a certain period of time, some of the treatments actually are no longer recommended. So getting that information is going to be key, and then communicating it to the hospital is also going to be important. Document, document, document. If your patient had a seizure, was it a tonic-clonic? Was it a focal? Was it a grand mal or a petit mal? Do we know how the the seizure occurred? Did they hit their head? Anything that you can put into writing and also share and communicate with the hospital is going to help them treat your patient. And that's not just with the seizure and altered mental status, that's with any patient. How do we treat these patients once we have found it? So when the stroke is caused by a clot, they will give clot busters and actually see almost immediate improvement with patients. If it's not caused by a clot, then we don't give clot busters. So if it's a hemorrhagic stroke, they're not going to be able to do anything in terms of medications that will stop or move anything because there's nothing to move. As I said, even a TIA, we need to try to transport. We need to try to get the patient to the hospital because that TIA was caused by a clot. And while it has moved from where it was, it's eventually going to get into a smaller vessel and can potentially cause a bigger issue in a very short period of time. Seizure patients, well, if they're still seizing when you get there, you can't hold them down. I mean, literally, that is no longer, we don't put anything in a seizure patient's mouth and we don't hold them down. But we do want to make sure that they're not going to harm themselves. So if they're sitting in a chair and they start to seize, then you want to help, ease them onto the ground. If they're sitting or lying on the ground and they're about to smack their head during the seizure on a coffee table, you should probably move that out of the way. Blow-by oxygen is going to be important while they're seizing, and then immediate oxygen application after the seizure has stopped. If you put a patient who is seizing or who has seized on a backboard, you want to secure them using straps. The problem is if they start to seize again, I've just told you not to hold them down. But if you let go of the straps, they'll fall off the backboard. So you lighten the straps and don't tighten them as much. We suction in between seizures if necessary. We provide ventilation and we transport, especially those patients who are in status epilepticus, which you remember is multiple seizures that do not stop. We have to remember that headaches can cause altered mental status, migraines. There are neurologic disorder, neurologic emergency. But we do have to understand that headaches could be an underlying condition or caused by an underlying condition, such as a tumor. It could be that it is the first sign that a seizure is about to happen. It could be because of an infection, or it could be after a trauma. So don't just go, oh, it's the headache. Give them the appropriate assessment just to make sure you can rule out any more significant issues that may be going on. If it is a migraine, ask them what they need. Oxygen can help, but they may not be able to tolerate it. It may actually make things worse. Drive quietly and slowly, so no lights, no sirens, to get them to the hospital. In our stroke patients, we're going to support the EBCs. So we've done our FAST, or we've done our pre-hospital stroke scale. Consider the fact that they may require a nasal cannula because of the droopage or the lack of tongue control. It may be causing issues, but they may still have a gag reflex. Maintain oxygen levels at 94% or higher if you can. We're not looking necessarily for significant high levels of oxygen therapy because that can impact your patient's intracranial pressure. But if they are in respiratory distress or they're hypoxic, obviously don't withhold treatment. Just no hyperventilation and make sure you've got appropriate oxygenation going on. You've got to protect your patient. So they may be paralyzed. So obviously you're not going to be like, hey, sure, get up and walk to the stretcher. But if your patient's altered, they may not realize they don't have control over their limbs. And so your goal is to protect the patient from further harm. Talk to them. Just because they've had a stroke doesn't necessarily mean that their mind is not sharp. I once helped a coworker in another part of my building. And after she got to the hospital and got her clot busters, she actually came back 6 weeks later and remembered everything. And she had limited deficit. She did have some speech therapy issues, but otherwise she was fine because we treated her quickly and got her the clot busters, those thrombolytics, to help. Time is brain. The longer they go in a stroke without further medical care, the greater chance that they're losing additional brain function. And, they may get some of it back, but once tissue dies, tissue doesn't come back. When you arrive at a seizure, remember that your patient, if they aren't actively seizing, they're likely in a postictal state. If they are seizing, assess as good as possible. Look for, you can't assess the airway and the breathing, but you can look for major bleeds. You can potentially check to make sure that pulse is going on. And let's be real. If they're seizing, they have a pulse. The question will be, do they have it after the seizure is over? Don't force oxygen on them, but consider blow-by. At least it's in the area. Assess your patient for trauma, and spinal immobilize is necessary. Don't restrain that patient. It can cause further damage if you try to hold them down. As that electrical storm is happening in the brain and the muscles are getting uncontrolled messages, if you try to hold it down, it can actually cause further harm. So I can't stress that enough. Don't restrain a patient having a seizure. But if they are suspected of having spinal or head trauma, and you've got them on a backboard, don't just let them go and be like, good luck to you, don't fall off the stretcher. But realize that tight restraints may be part of the problem. If you've got a patient who has had a seizure and is coming out of the postictal state, they may want to refuse. They may say, look, I'm fine now. Yeah, I did have a seizure, but I'm an epileptic, I'm used to it. And they make clear in terms of being of right mind to be able to give informed refusals. Your goal is to encourage them to go check their hospital, their doctor, to make sure they understand why. So let's look at why they've had the seizure. Let's make sure that we encourage them to go to their doctor to check their med levels if that's the case. And if necessary, if you still think it's not the best idea, call med control and see what they're saying. Signs and symptoms of your altered mental status in general, if it's not related to a stroke or to a seizure, can be hard to figure out because of the fact that they are so broad, both confusion, disorientation, all the way to unconsciousness and a coma. In those cases, we're going to go from A to Z. We're checking out our primary assessment and treating the signs and symptoms as we come to them, recognizing we may never figure out what actually caused the altered mental status.